So, well, thanks very much for joining. And there's obviously, I'm delighted people are interested in the national audit. I'm going to try in the next, I'm going to keep this quite short. I'm hoping this talk will be no more than about 15 or 18 minutes long, and then there'll be just some time to ask me questions, which I will do my best to answer. My goal is to just talk about what the national audit might be useful for in the coming months, and to give you a sort of an update on the audit's progress, because obviously we've gone silent since the pandemic started. Just to mention the data entry for organisational data, which is now open. To touch on some of the updates we've made to the platform to allow some changes that may help around remote consultation. I'll then briefly mention, although I've very little to say about best practice tariffs, as they are suspended. And then I'll touch on the annual report at the end, and some of you may have had letters about the annual report. So yeah, I think it's been a crazy time these last few months. The pandemic continues, as you heard me just mentioning, and I think colleagues around the country are all talking that the R number has risen above 1 in the UK, that we are seeing not just cases in the community, but they're starting to trickle into the hospital. And we know from our friends and colleagues in other countries like France that they have seen the sort of intensive care admissions rise again quite steeply. So I think we're all braced that this is not going to be a quiet winter for any of us, and we need to be prepared to continue to manage services with as much remote working as possible for quite a few months longer to come. But that said, you know, COVID is a pandemic of, you know, global importance, but actually we're rheumatologists, and people will continue to develop inflammatory arthritis over the next years amongst all the other rheumatic diseases. We're aware that this is going to happen in the context of very stretched surfaces, and with a significant reduction in our available face-to-face activity, and most of us doing a substantial portion of our clinical consultations using online tools or telephone. But that said, our desire to treat people well hasn't diminished, and we still want to deliver the very best care for patients, although it is difficult in these times, and sort of concepts of treat to target are undoubtedly, for some of us, feeling slightly remote. So back in March, the national audit effectively paused. We actually never closed the website, but there was a message that we would not expect anyone to be recruiting new patients to the national audit. And in fact, we didn't see anyone enter new patients from March until August. We did see people updating the data on existing patients. We saw patients who were being, sort of follow-up data were being entered, or some retrospective admissions. But it's actually, it's only really this last few weeks that we've started to see people using the audit platform again to enter data. And the number of people being entered into the audit are still very low. But one thing I just mentioned, we published the supplementary report in just a couple of months ago, a month ago. The supplementary report was an addendum to the first year's report, and it was written because when we published the year one report, we obviously published that with the first 12 months of data, but that couldn't include any of the annual review data, because only patients who had been recruited at the very start would have made it to a 12-month follow-up to be able to analyse annual review. So we delayed our first analysis of the annual data for 6 months, and that was written and drafted in January, and there was some delay because of COVID publication, but it's now published. And it includes the 12-month data, proportions of people having annual reviews, the proportion of people having the different components of the annual review, how many people need joint replacements, how many people died. And actually there's some really, I think when you look at the national audit and you look at what we're doing, a lot of what we're doing is about measuring process. And sometimes it can be hard to remember that the reason we measure the process is there is a very clear relationship between the process measures and the outcomes that matter to us. Now, I think we say that, we know from trials that the process measures should. The whole reason the process measures were put in place is because the trial evidence suggested they were what predicted outcomes. But we do now have, and I'd encourage you to read the supplementary report, because it is interesting. I think it shows there is variation in care around the country, and we also now see quite clearly that our process measures are very strong predictors of outcome. I always feel slightly bad, because when you say there's variation in care, it sometimes feels like you're reading a school report, and people who are providing care which appears on the process measures to be less good, you feel that's a personal reflection, and of course that is very rarely the case. The vast majority, when you look at variation in care, it is driven by resource, it's driven by so many other external factors. And so I think the crucial thing is, when you look at the national audit, you look at it not with a view to say this is a personal reflection on performance, but this is a tool and a lever for change. And I mentioned that in this context because at the moment, now more than ever, if you said there's some variation in care, I think all of us would say, well, yeah, there's some variation in care, but at the moment it is really tough. We have lots of backlogs, follow-up appointments. I certainly feel that our services, and in other places, to the extent that we're being sidelined to make way for other services, we've lost resource space due to the pandemic. Now, one thing that NEIAA offers is it puts rheumatology on the NHS agenda, because the metrics that come through NEIAA are reported to the CQC, and so that has a substantial weight when the trust is looking at service performance across the sort of the breadth of clinical directorates. And by the fact that NEIAA flags the CCG, it becomes then a very powerful lever at our disposal. So we can, really use it as an advocacy sort of tool for our service to say, if we're not doing if we're not doing it as well as we should be, if we're not doing as well as our peers are doing, then this is a justification for saying we actually need the resource to be maintained in rheumatology. We need the resource to deliver care. I think these next few months are going to be really trying times, and I know that the managers have so many challenges on their plate. But I hope that NEIAA will be useful and will be a resource rather than a hindrance. So I should say a few things about the website. So the first thing I wanted to say is organisational data, and this is obviously interesting because we're potentially going to be capturing a snapshot of information about departmental resources at sort of midway through the pandemic, and this will be useful information to yourselves and also to the BSR. The information we collect in the organisational data captures staffing information. It captures information around our resource and access to allied health professionals, and our online or out of hours and telephone advice line support. I'm going to play a short video just very briefly, just so when you first log into the audit website, the organisational data is in here, and the organisational data, you can see I've just highlighted on it. That data entry form, people have asked a few questions saying, well, when I enter that, am I entering that for how we were last year, how we will be when the pandemic's over? And the answer is, I think the data that we're looking to capture are about how your service is staffed at the time we're collecting the data, which is from September this year until March, April next year. So I would answer the questions as your service is currently running. When you enter the form, the other question we sometimes get is, and this is the organisational questionnaire. It's not a long form if anyone's not actually gone in and completed it, but there's a question about, for example, how many whole-time equivalent consultants work in your department. And if you click on the icon to the side of that, it does give some instructions to some of these. The little blue icons with question marks answer quite a lot of the questions people have just in general in the audit. But for example, people say, well, how many consultants should I enter here, and how do you count an academic? So we're only looking to count whole-time equivalent for NHS contribution. So if you have an academic who does 50% NHS, 50% clinical, they would count as a 0.5 whole-time equivalent for their NHS clinical work. I think that there are other surveys ongoing as well, and so this is obviously a relatively limited set of data we collect through the national audit, and I'm aware that there are other surveys going on around the practice, looking at other aspects of care delivery, and so I think this is only going to be one piece of the puzzle. So yeah, the way we deliver care has changed very dramatically. This is a very stylized picture of my desk delivering a consultation. It's bizarre, the world that has become the clinic, and I'm doing a lot of telephone. I'm doing a little bit of video consultation, and notice my new face mask here. I found this at the weekend actually from well, I probably should be brand neutral, but it was from a very nice shop in London, but they do online. If anyone's interested in it, I can give you details afterwards. Anyway, so yeah, we're doing this in the remote world. So there are a few things that we've changed in the platform. So when you log in to enter a patient into the website, you should be familiar with this, and you're going to click on demographics, diagnosis. We ask you to add in the diagnosis tab this thing about the consultation, whether it's face-to-face, telephone, video call, or not known if it's an admin member of staff, and who's entering the data. But this is a way that we can capture some people's how people are delivering their consultations. This was a question that we've added in to allow, so when we're looking at the data, we'll have context about the format in which consultations have taken place. A question that has come to us several times in recent months has been, well, you know, we just had a telephone call, we didn't record a DAS, or we didn't record, you know, the CRP ESR, do we still enter the data? And the answer is yes, enter as much data as you can. And if the ESR and DAS aren't there, then they're not there. And I think we have to work with the information we can. It's not ideal, and it'll leave the form with an orange flag on it saying it's an incomplete form, which if you're like me and you like the forms to all light up in a nice green color, it'll irritate you slightly. But I think if you had a telephone call, collect it. There is no time window on when you can enter the data, but we do have time windows on when the visit should have taken place. Some people have said, well, you know, we didn't see anyone March to you know, August or whatever, or March to July. So their 3-month visit fell outside of the time window. What do I do? So that data just has to be missing. I wouldn't tell you, I wouldn't ask you to put a you know, a visit from August in and pretend it was within the 3-month window of within the window of the 3-month consultation. So if in that case, it just has to be missing data. If you do a remote consultation, the other thing is about remote DAS scores, and I've just got a couple of slides on this, because some of you will also have seen that in the clinical baseline, we have added this bit at the top, which says patient PRO baseline not yet started. And actually, this is because what we have done is and I'm going to show you a little video of this in a second. We have added within the patient-reported outcome measures a self-reported joint count. So when you look at the clinician baseline or the clinician follow-up, if the patient PRO had been completed and they had included the tender joint count and swollen joint count, they would populate a little number just in the box here, just below the box here. It doesn't edit the DAS. It just shows you what the patient reported as their swollen joint count and tender joint count and what their global was. It's up to the clinician to decide whether they then use that information or not. And yeah, so self-reported DAS is it's not a novel concept, and there's been a lot of research done on it. If you look at the relationship between self-reported DAS and patient and clinician-reported DAS, well, actually, tender joint counts have really quite a high correlation. Tender joint counts have a correlation of about 0.78. Anyone interested in correlation? That's a good correlation. Swollen joint counts, the correlation are not quite so good, 0.59, 0.6. But still, the correlations are not bad. There is an important caveat to that, and anyone interested in correlational sort of type analyses, it's worth remembering that correlation is different to agreement. So you can have an excellent correlation between two variables, but if, for example, the clinician always reports the joint count at 2 and the patient always reports the joint count as 4, and that's what they always do, then you could have a perfect correlation, but they don't agree. So when you look at agreement, and sometimes there's these things called Bland-Altman plots, which are the sort of style of plots on the right-hand side of the page here, where the left plots, and I'm sorry it's cut off slightly, but at the top is swollen joint count, the bottom is tender joint count, and on the left that's just plotting mean patient joint count versus mean physician joint count, and on the right it's plotting the mean difference. And what you see is that for swollen joint counts, they tend to actually look like the agreement is slightly better. But it particularly as the joint counts go up, it tends to lose its agreement. And I think the message is that patients in remission, if they report a low swollen tender joint count and have a low patient global, they probably have a low swollen tender joint count, and we can use that. For patients who are not in remission, then for people who've got high tender joint counts, I think that's where we're aware that there may be discrepancies. And of course, things like chronic pain, fibromyalgia, and the overlap there make it challenging. And I think we just need to be mindful that someone who has a self-reported high DAS, I don't think there's a robust enough evidence to use self-reported DAS to make decisions about starting biologics, for example, or treatment switches. They probably need face-to-face visits still. There's a whole other conversation to be had about that. So just to show you what this looks like, this is, again, it's a short video. So when you log in, if you once you've logged into the clinical baseline, you can click on the patient baseline. So in this one, you can see, instead of saying not completed, it says is completed. So I can click on it and I could see what they're done. And this is what the patient would say. This one hasn't been completed, but the first thing is, at the top of the page, I'll just scroll down a bit, there's the link to the NRAS Know Your DAS, which is a brilliant publication. It's a PDF, and that's a self-how-to guide. There's also some questions of some help buttons the patients can click over, and then they add in their tender joint count first, and then their swollen joint count to mannequins. And again, there's some advice on that. So that's the self-reported joint counts. It's an imperfect system, and I'm sure that it'll be improved in years to come. It's obviously, you will see it because it's been mirrored in the BSR EPROMs, and so the same platform is there for capturing tender and swollen joint counts. I've been using this actually. I have found it really interesting. I think it's helpful and insightful. And I must confess that my use of PROMs in clinical practice, as opposed to simply for research and sort of long-term follow-up, has changed. And I am now finding I'm looking at the PROMs with a lot more detail, because now you lose that sort of visual interaction with the patient, the nuance of facial expression and everything. I actually find the PROMs are becoming more powerful. Last couple of slides then. So I just wanted to say best practice tariff. The audit remains the means by which we'll collect data on it, but the best practice tariffs across the board are currently suspended. And we will keep you updated if that changes. And the other thing is of course, that we have passed the date for the annual report cutoff. That was in May. We were given instructions from HQIP that we would not be doing outlier notification at that point. We have now been given a green light to notify people of outlier status, sort of. So we're not going to be publishing a list of outliers from the annual report. I think, to be honest, it's a slightly meaningless situation, because the outlier status is based upon your performance before the pandemic. And I think most of us would agree that things have changed a little bit. And so it's historic data, and how much use it is, I think you have to be really mindful of how much has changed. However, we are asked by HQIP to inform all the trusts who are identified as an outlier only at the 3 standard deviation level. So we're sort of taking the more extreme level, and we are letting know that they were an outlier when the report analysis, when the data cut was done. And this is important information, but it's in the context of a pandemic. So some people, some trusts will have received an email about that. And I think I would go back to what I said at the very beginning, which is I would see this as a lever. And for those of us who are finding resources are being squeezed from us because of the pandemic, this is a lever to say, actually, hold on, there's a CQC metric linked to our specialty. This is really important that we continue to deliver care, and don't forget us. So I've covered what I wanted to cover. Thank you for listening. I see there's a question that's come in. I'm going to stop the recording because I think Q&A never works quite as well in recording, but we will keep the chat record. And so thank you very much all for listening.